Today on Town Hall.
Their 2022 data says 4.9 million people were diagnosed with an AKI in 2022, one every 7 seconds. And so I think the reason we're still struggling with it is that it is a manual process today.
My name is Bill Russell. I'm a former CIO for a 16-hospital system and creator of This Week Health, where we are dedicated to transforming healthcare one connection at a time. Our Town Hall show is designed to bring insights from practitioners and leaders on the front lines of healthcare. All right, let's jump right into today's episode.
Welcome to another episode of This Week Health, a community conversation between friends and colleagues. I'm Reid Stephan, CIO at St. Luke's Health System in Boise, Idaho. And I'm joined today again, we've been on here before together, with my good friend Todd Dunn. We've collaborated in the past. We've known each other for a number of years. For those that don't know Todd, he has a rich career history. He led innovation at Intermountain Health. He most recently led innovation at Advocate Health. He's now taken all that knowledge and is in more of an advisory role to different health systems across the country. I think you're also in the midst of writing a book called The Innovators Journey. And Todd, welcome, and just excited to have a few minutes to visit today.
Oh, thanks for having me. It's always fun to connect with you, Reid. We go back 6 or 7 years now. So yeah, that's pretty awesome.
It's been great. And so I have a specific topic that you and I have discussed a little bit over the years and really want to explore, because I think you're onto something, but I think there's some level setting that we'll need to do as we kind of bring our listeners along on the journey. And so we're going to talk today about acute kidney injuries, or AKIs. And specifically, what are some of the emerging technologies or solutions that can make a meaningful difference in this area? But let's start with, what is an AKI and how is it different than a chronic kidney disease?
That's a great question. The formal definition of acute kidney injury is a sudden decline in kidney function. Pretty high level. It typically happens for 3 reasons. You got a serious infection, you have blood loss, and it can also happen because of the medications that you're taking. And how does it differ from chronic kidney disease? Is they're related, but let me elaborate a little bit why. Chronic kidney disease is typically known or driven by high blood pressure or diabetes. What a lot of people don't know is that people who get an acute kidney injury can develop chronic kidney disease, because that's a big risk factor for acute kidney injury and chronic disease together. So predominantly chronic kidney disease, high blood pressure, diabetes, but a risk factor for it is acute kidney injury.
Okay. How quickly can an AKI develop, and why is early detection then so important?
It develops in hours, and there are different stages of it based on what they call the kidney disease. It's called KDIGO. The reason that it's important is when you have an acute kidney injury, the insult to the kidney progresses over time. It's a duration issue. So if you put something under pressure for too long, it's going to kind of collapse. And so AKI is level 1, 2, and 3. And then, of course, you can advance to actual acute kidney failure or dialysis. The reason that interventions are so important, and Dr. Engelman, who started as the founder of ERAS, and it's kind of in the cardiology space, you know what ERAS is, said that once a nephron is injured, it's injured. Do we know how bad per person? Not necessarily. So the earlier intervention is so important, because the earlier you intervene, the better off you are. I'm going to give you a little bit of data, and I'm just going to read it so that I make sure that I give respect to the researchers. 2 years after AKI, 37% of AKI patients have evidence of renal injury after surgery. 2.4 times the risk of long-term renal dysfunction, regardless of AKI severity. That's why getting it early is so important, so that you can prevent long-term harm to someone's kidneys. That's on the personal patient level, of course.
Okay, so that's a good backdrop, high level, for non-clinicians of AKIs. You kind of touched on the impact it can have to patient outcomes, which is the most important, but also financially. Maybe just talk for a minute. what's the impact then to financial operations for a health system?
Okay, I'll give you one. I was just looking at some data from a system I've been working with. In elective surgeries, what they showed is that someone with an AKI, with a mix, of course, of acute renal failure, because these often progress all the way to renal failure, had a 7.4-day increase in length of stay.
Wow.
So, and you and I've talked about this before, more and more in cardiac surgeries and these procedures, we're getting bundled pre-negotiated payments that they'll say, hey, here's the dollar amount for, say, a cabbage. And in that bundle, they include a number of days of stay that should be typical. Well, if you go beyond that, it's your problem as a system. It's almost like a readmission rate, right? The increase in readmissions at that one system is about 27% above normal for it. And the average cost increase was $19,000 per case on average. And so for a healthcare system, from a financial viability perspective, it's really important to meet the criteria of those bundles and the amount of money that you're paid for doing the work you're doing. If you miss it, if you get an acute kidney injury, it's a negative impact to that. If a patient goes to dialysis, it's also a negative impact already to an EQMS score. And just recently, October 1st of 2024, CMS has put out a report that they're now going to start requiring the reporting on acute kidney injury. And if we go back to October 1st of 2012, the announcement on CAUTI, we all saw where that went. It basically became a never event. And I think that CMS kind of tips the hat. So it's going to become more of a problem financially over time too, as CMS is diving in as a reportable incident.
Okay. So if we can accept that solving AKIs is important, it's important for the outcome and the health of the patient. Financially, it's important then for systems that need to have margin to accomplish their mission. What's your opinion on why it's been such a persistent challenge for hospitals and health systems to solve, despite advances in technology, despite improved patient care protocols? What's been the barrier to progress?
A couple of reasons on this.
Mm-hmm.
I think if you look at an injury to a kidney, it's not automatically destructive to the body. Okay. It's just not. Long term it is, but it's not immediately destructive to the body. The other reason is I want to give a piece of contrast for it.
Yeah.
I think a lot of people have heard about the Swan-Ganz catheter. That's a catheter that goes to the right side of the heart to manage. But what they're doing, and I think about this as a catheter. So now I'll explain why I think this is important. It determines or understands the function of the heart, the flow of the heart, and the pressure around the heart. So we have technology to monitor the heart, the brain, and the lungs. What do we have for the kidneys? We use gravity-fed Foley's. And by the way, it's actually named after Dr. Foley. And from 1930, it's still a gravity-fed Foley. And a lot of us who have done observations in the OR and the ICU, you walk in and you see that these gravity-fed Foleys actually get dependent loops in them. So the reason that I believe it's been so hard to reduce the number, which I'll give you in just a minute, of definitive healthcare offers, that of the count of those every year in the country, is because we haven't put enough innovation and investment into digital transformation of the kidney, just like we have the heart, brain, and lungs. So we're lagging. It's almost an inequitable approach to a vital organ. But if you have a heart problem in the ICU, it's typically more severe than a kidney issue.
Right.
But in reality, to a patient, they want to walk out of there with all their organs in good space. And here's one for you. Most people don't know. Let's assume definitive healthcare is accurate. Their 2022 data says 4.9 million people were diagnosed with an AKI in 2022.
Okay.
1 every 7 seconds. And so I think the reason we're still struggling with it is that it is a manual process today. If urine gets stuck, a nurse has to do something manual.
Okay.
To know urine output, a nurse has to look at a bag, and the standard is only once every hour, and it's manually entered into the EMR. So it's the processes and the lack of technology that's causing the lack of improvement in the number.
Okay, that helps. So I think we've admired the problem or the opportunity long enough. Give
Yeah.
us hope. What are some of the either existing or emerging innovations that you are seeing or aware of that you think will help move the needle in this space in a good way?
Great question. So we've had for the longest time a serum creatinine test that can determine acute kidney injury. We also know it's a lagging indicator. So we have that. We have biomarkers. That's pretty encouraging. But biomarkers, as you know, is a really rifle understanding of a particular biomarker and doesn't give us all the types of acute kidney injury. The one that I have been following for 7 years now is a company named Accuryn Medical. And what they have done is automate urine flow. Their technology is just as simple and clean, but effective. They basically sweep the line every minute, which means literally down to the second, they can know urine flow versus checking it every hour, assuming that you check it every hour.
Mm-hmm.
And that data on the urine, which is the vital sign of the kidney, goes back into the EMR. So now all of a sudden, versus kind of accurate-ish hourly data, you could have accurate urine flow every minute. And it automates all of it. So basically, you've digitally transformed the kidney, kind of like the Swan-Ganz catheter. You now know the function flow and you can know the pressure around the kidney. They've got some really good data and results so far. I brought them into Atrium and know a number of other systems that are using it.
Do you have any success stories that you could share that just would kind of help paint the picture for listeners of what this means then at the bedside for the patient, the outcome?
Yeah, there's an academic center in the Midwest who, through the evaluation that they did, actually did not have one case of acute kidney injury escalate to dialysis. So when you think about that, a dialysis patient, some of those stay an extra 13 days. And so not only did it prevent the progression of injury to the kidney, it also stopped really financial pain for the system. There's a burn center in Tennessee. It's called the Brockway study, and it reduced CAUTI counts by 90%, which is amazing, especially in burn patients, right? There was a poster done by the Children's Hospital of Atlanta. They went 512 days without a CAUTI. And so you're starting to see the data come because of the application of it. And there are a number of other studies and things I can share with the audience that shows the Accuryn device was able to pick up kidney insult 33 hours before a serum creatinine score. What made that come to mind for me is you asked me, why is it so good to catch it earlier? How can you catch it early? Imagine if you could catch it a day ahead of what is the traditional lagging indicator of serum creatinine. It gives the clinical teams the data they need to prevent the escalation of it for the patient and for the system.
Interesting. So in your kind of tracking of this company and this solution and the places you've been, what's the change management like? Like, are there any beliefs that are held that have to be countered against or collaboratively talked through in order to expand the mind to the possibilities?
Yes. Yeah. Well, that's a really good question. When you're used to having data every hour at best and accurate-ish data, what do you do now when you have it accurate down to the minute in a digital form in the electronic medical record or in your Epic flow sheet? What do you do? So there's a change management thing there. And I think about it in two pieces that you and I've talked about before. I think about think flow.
Mm-hmm.
How do I think about it today? And then actually the workflow. How do I work with the information that I get? So there is a change management piece there. You're still using a Foley, so that part doesn't change, but it's a little bit of a smarter Foley. So you've got to get used to that. And so there's some workflow implications. There's some think flow implications, only for the better, but I would never want to negate the fact that you're asking clinical teams to do something new. It's better. Absolutely. It takes the documentation burden off the nurses. It gives the doctors and the nurses information that they need. But to say that there's no change management would be too dismissive of people doing really incredible work.
Yeah, and I think that's a really important perspective to bring to it. No matter how excited you are, how clearly you see the benefit of the capability that you want to introduce, you have to your point, not be dismissive and respect the fact that this is a change. And so you said something that was interesting is you really need to talk about it from the kind of broad platform benefits it could provide. And so you talked about the reduction in clinical burden or clinical documentation burden. Like that would be a key talking point then to help folks kind of understand this is a rising tide that can benefit a lot of our workflows and the patient and the outcome.
Interesting you bring it up. There was a system in California, I don't know if I can mention their name. They did a study, a time and motion study. It said it takes 2 hours per ICU bed per day to manage urine. They switched to Accuryn and reduced it to 5 minutes. And why? Because you're never having to touch the Foley. You're never having to document urine flow. So it takes all that work off. It could even give you an intra-abdominal pressure score, which we know is very related to injury. And it's all based on this kidney disease improving global outcomes KDIGO score framework. So it's using standards. You make an interesting point. I think the device honors, especially the nurses' desire to spend more time with patients. I mean, which nurse? My mom was a nurse. She did not like having to milk a Foley or, try to manually document urine.
Mm-hmm.
But I think it honors their time. And like you mentioned, I think we also have to give it honor to understand the think flow and the workflow changes. While they're very positive, there's still change.
Yeah.
And spending a lot of time in the ICUs, I was able to see it. They're very happy. You'll appreciate this because you're an innovator. There were 30 of them just getting ready to deploy. And one of the nurse managers put a tag on it, said, "Do not remove from the CT ICU." And that's when I knew we had done something for the people who are doing the sacred work of patient care, is when they put a tag on a device to not remove it from the bedside for them. Yeah, you got to honor people who are doing that kind of work, Reid.
Yes, it really is sacred. You're right. Yeah.
Yeah.
And you've used a phrase before that like empathy is the heartbeat of healthcare. And so my experience, innovation is only as effective and gains as much traction as it then really addresses that empathy quotient. So any last thought you would like to share about this?
Yeah, that empathy word's a really interesting one. Taking a burden off of nurses of having to manually manage a 100-year-old Foley technology, I think is empathetic, because it tells them that you value their license, their knowledge, the work that they do, and that they actually would probably prefer talking to a patient than milking a Foley. But I think my closing thing is there are 5 codes that are related to acute kidney injury: N17.0, N17.1, N17.2, N17.8, and N17.9. What I suggest to systems who want to really think about digital transformation of a manual organ to a digital organ, the kidney, is to pull that data and look at a few things. Look at the average length of stay related to those codes compared to someone who didn't get the code. If you can, look at your readmit rate, because we know there's data that suggests that it's much higher because of the insult to the kidney. And if your system happens to track cost per case, then you have the ROI understanding of why you need to treat the kidney as sacredly as you treat the heart, brain, and lungs. That's what I would do to have the data argument, because we really need to debate the data, and then we can go do observations and those things. But I think that's the thing I would tell everyone to do. Email me. Feel free to reach out to me at todd.dunn@gmail.com or todd@theinnovatorsjourney.com to have the dialogue. You and I have talked about this. My wife nicknamed me Captain Kidney the other night because I've been so passionate about it for many years. But my advice is take a long, hard look at this. Patients deserve for us to do better by them, and only innovation and technology can really help us get there to where you go from high variability of taking care of the kidney to high reliability and standardization of the data and the workflow and the think flow. I think that's what we really need to do as a system. We owe it to everybody in the system, frankly.
Well said. My guest today has been Todd Dunn, innovator extraordinaire in healthcare. Todd, just really appreciate the background, insight, and context about AKIs, the perspectives that you bring, but also some really pragmatic steps that listeners could take just to kind of take a sample of, is there something here that we should maybe look at and dive into deeper? All with the idea that we are better together.
Yeah, we're always better together. And I think the sharing and lifting all of our boats together is the right way to approach healthcare and especially innovation.
Thanks for listening to this week's Town Hall. A big thanks to our hosts and content creators. We really couldn't do it without them. We hope that you're going to share this podcast with a peer or a friend. It's a great chance to discuss and even establish a mentoring relationship along the way. One way you can support the show is to subscribe and leave us a rating. That would be really appreciated. Check them out at thisweekhealth.com/partners. Thanks for listening. That's all for now.